the management of complex mental health medications during pregnancy and the postpartum period, next on All Things Women's Health. I'm an obstetrician-gynecologist of 30-something years. I'm a husband, I'm a father, I'm a grandfather, I'm a small business owner, I'm a Catholic. I'm a lot of things. Certainly people use a lot of names for me. But right now, I'm your host as we talk about, really, all things women's health. Everything from infertility to childbirth options, from menstrual problems to mammograms, homeschooling curriculums to personal trainers. It doesn't matter. If it affects women, it's on our agenda. And our agenda today is an important one. We're going to talk about the use and the management of some sometimes complicated medical management issues, complicated medicines for people struggling with mood disorders, depression, anxiety, ADHD, you name it, during pregnancy and in the postpartum period. And I brought in today a terrific guest who's going to help us navigate these complex waters. Joining me today is my guest, Delaney Baumann. She is a remarkable young professional who's been in our area for quite some time, who's going to talk to us about these issues. Delaney, welcome to All Things Women's Health.
Thanks so much for having me.
Yeah, absolutely. Well, let's start. You're a nurse practitioner, and let's start. We've had other nurse practitioners on the show, but tell us a little bit about you, about how you got to where you are, et cetera.
Sure. So I'm a Fort Wayne native. I was born and raised in Fort Wayne and initially started my career in nursing, working in the emergency room. And I have always had a passion for mental health. The patients that came into the emergency room in psychiatric crisis were always my favorite patients to care for. And so as I continued within my career, I pursued my family nurse practitioner degree and worked in family medicine and primary care for about 6 years.
Sure.
And I just really found an enjoyment in caring for patients that were struggling with mental health. So from that, I desired to really be competent and confident in my ability to prescribe and manage psychiatric illness, and just wanted to be able to be a resource for patients that were in more of a rural setting. And so I went back to school and obtained my Psych NP certification. And then from there have just kind of progressed into really working on kind of focusing a very niche into perinatal mental health and prescribing medications for women in that time frame of their life.
Yeah, so I mean, to be more specific, you worked in mental health, in pregnancy, with medications. Because I think most people, when they hear someone like you say, oh, I have an interest in mental health, they're thinking counselor.
Right.
They're not thinking medications. They're thinking more somebody like me to prescribe medications and someone else to do counseling. But you've really taken it upon yourself to fill an incredible void, which is the medical management of mental health problems.
Yes.
Why do you think you went that way? What happened that made you say, oh, I want to do the complex medicines? Because this isn't easy stuff.
Right. I think I had a patient not long after I was working in primary care that came to me and had previously been stable on a medication to manage her bipolar disorder. And she was taken off of it during her pregnancy, and it wasn't replaced. And so I was caring for her newborn, and she asked me very nicely, just a couple days after her son had been born, if I could re-prescribe this medication for her because she had been without it for the last 9 months and was near crisis.
Wow.
And so from there, that really kind of lit the fire to see that there really needs to be a bridge between psychiatry and OBGYN because this is a gray area and an area that I think oftentimes, and correct me if I'm wrong, OBGYNs end up in a difficult situation to make decisions on whether to continue medications. And oftentimes psychiatry will just dismiss patients that are established with them once they become pregnant. So
everyone's afraid of pregnant women.
Yes.
Whether it's, dentist or psychiatrist and I get it, no offense. I'm afraid of other things that I'm not familiar with in medicine, but pregnant women often find themselves kind of in that wasteland of help. And for years I've struggled because it's not our area of expertise, but yet sometimes we have to try our best to develop it. So hearing about you is extremely exciting. And I can only speak to our market here in northeastern Indiana, but I don't think it's terribly different from other markets in that today most psychiatrists are not doing, I don't know the right words, you correct me, but what I would call primary psychiatric care, right? They're not seeing a patient over and over, longitudinally through time, making medication changes. They are assuming someone else is doing that.
Right.
Is that unique to our part of the country, or do you feel like that's probably common everywhere?
I think that that's probably common in a lot of spaces, just because they're in such such high demand that they must kind of, primary care has had to step up and manage patients that even probably 15 or 20 years ago, they wouldn't have been managing. Psychiatry would have been managing. Yeah. So yes, they definitely take on a little bit of a different role.
Yeah. So it's been a big challenge, and our patients unfortunately are caught in the middle there. Mm-hmm. Yeah, but we're glad you're here.
Yes, I'm glad to be here.
Yeah. So let's start kind of at the beginning of when we tend to encounter challenges, at least from my perspective, and that is someone is on a medication for maybe depression, maybe anxiety, maybe bipolar disorder, maybe ADHD. Those are the big ones that come to mind. Mm-hmm. And they find out they're pregnant. I guess I should back up. Can you think of other conditions besides those that I named that are common?
I think those would be the most common ones that patients would primarily be looking
the largest
for.
number of people that we encounter. And so they're taking a medication. Presumably they're doing pretty well. Mm-hmm. And now they realize they're pregnant. I can't tell you how many times they just stop their medicines. I'm sure you've seen this, and not good. That's not a good thing.
Right.
But how do we even begin to approach that topic? Should I stop my medicines?
Mm-hmm. I think that it's a varying decision. It's a dual decision-making process, but I think there are some major things that we must consider. And I think in healthcare and medicine in general, in primary care, my discussion was always risk versus benefit when we're talking about medications. But in this realm of perinatal mental health, we are now talking about risk versus risk when we're talking about a mom that is experiencing a mental health condition in pregnancy. So we're talking about risk of the medication exposure to the fetus, of course, but we're also talking about risk of untreated mental health exposure to the fetus, which we also know carries its own risks, like preterm delivery, small for gestational age. There are a lot of things that go into that discussion. So this isn't a risk versus benefit, that there is no risk on either side. There's risks on both sides.
It makes me think of, in the early days, arguments about seatbelt use in pregnant women. And those that weren't in favor would say, well, there's a risk to the baby of the seatbelt causing trauma. And we would always point out the greatest risk the baby faces is the mother's killed in a car accident. No mom, no baby. Then I like the way that you said that. It's risk versus risk. Mm-hmm. But in medicine, a lot of times, and I think just human nature, we don't really like that concept.
Right.
But I like to point out to patients every day, we're making these complicated risk assessments at our subconscious level. I mean, getting in the car to drive to work, you take on a huge risk compared to not getting in the car. Mm-hmm. But you don't even process that, at least not at the conscious level.
Right.
But we need to make conscious decisions about a risk versus a risk. Mm-hmm. So if we started with maybe the most common, I guess, that would be the medications for depression, the common ones. Mm-hmm. We could probably say Zoloft, Lexapro, Celexa, and I'm using trade names. I'm in no way connected to these companies. Those are just the ones that pop into my head. Mm-hmm. Let's do that conversation first.
Sure. Yeah. So I think that a consideration for when we are thinking about a woman that has previously had a major depressive episode or an anxiety, generalized anxiety disorder, how long has she been in remission on this medication? I think that's a consideration. How significant or severe was that major depressive episode? Was she previously in a state where she was having psychotic features that were along with it, and she was also actively suicidal, and that was 6 months ago, and she was in an inpatient facility? So I think that's kind of where the variation in the conversation comes in. And also, again, we have to consider that if we take away a medication that is stabilizing their mood, we don't exactly know what pregnancy, the changes that are going on during pregnancy, and certainly postpartum, what they may face. And so taking all of that kind of into consideration to make a decision is very important.
But I think you're making a distinction, it sounds like, from that scenario that you described, clearly very important.
Right.
A previous history of inpatient psychiatric treatment,
Right.
illness requiring treatment, as opposed to maybe someone who's struggled with some anxiety, not functioning as well at work as they'd like to, so they took a medication. Those aren't the same two people.
Right, exactly.
And then I've also heard it said, if you could not take it, well, that's easy, don't take it. But you've got to think back to what it was like when you didn't take it, I suppose.
Yes. And in particular with anxiety, we know that, and especially with your practice, you have women that are deeply desiring to have a baby. And so the anxiety that comes along with those trials each month are anxiety provoking in and of themselves. And so that's another consideration too, is that you must consider the anxiety about, is my baby okay? Is my baby growing well? Am I going to birth a baby that's going to come home with me at the end of this? So considering, those anxiety factors too kind of all play a role in that decision.
Yeah, a common scenario that I saw this very day, someone that's had recurrent pregnancy loss, and now they're pregnant, and everything looks good, but that's often not a happy time. So they are riddled with anxiety, particularly as they approach the age maybe that they lost a child. They're struggling to function. Maybe they took medications in the past, and they're thinking, well, I'm not going to take them now. I'm pregnant, and I've worked so hard to get here. But at the same time, they may be harming themselves and harming their baby.
Absolutely.
Do you have specific feelings about specific anxiety, depression medications as we think about continuing versus stopping?
Sure. So when we think about, the safest or the most data supporting safety with regards to SSRIs, sertraline or Zoloft is kind of the one that comes to mind, I think is the most preferred within the OBGYN world, but certainly shows the most safety and data as far as, that goes. I think when we're talking about treating anxiety and depression, it's also tends to be very efficacious. So I think that, sertraline from a safety standpoint probably has the gold star next to it.
But, you bring a really important point out, and that is it's impossible to go look up on an online resource. If you look up Zoloft or you type the question, is Zoloft safe in pregnancy? No one is going to answer that question. And nor will they ever. It's just not going to happen. It's too frightening. It's too risky from a legal standpoint. But what I like to say is over decades now, we've become comfortable with the use of these medications like Zoloft or Prozac, some of the originals that are now 3 decades old. So collectively as a profession, pediatricians, obstetricians have become comfortable with pregnancy, breastfeeding, and the like. But that's not the same as looking up, say, Tylenol, where it says safe in pregnancy. That's never going to be the case with these medicines. That's hard for some people to accept. Absolutely.
And, it goes back to we don't traditionally do studies on pregnant or breastfeeding women.
Fortunately, we don't.
Yes, from an ethical standpoint. So I think that, bearing that in mind, we, of course, want quantitative data to support, safety and research that has been done in controlled trials. But unfortunately, we don't always get that.
Yeah.
So,
and then no insult to the competing companies, but you mentioned SSRIs. So medications like Zoloft and Prozac and Lexapro and Celexa, and my list will run out. There's many, many more. They're all competitors. They all tell us that they're better than their competitor. They're all similar, like cousins are similar. And so we often will extrapolate safety.
Right.
So we're very, very comfortable with Zoloft, as you mentioned. Say Lexapro hasn't been around quite as long, so I might be inclined to think, the Zoloft isn't working. I feel comfortable trying Lexapro, but it's about comfort, not necessarily about data.
Right.
Yeah.
Right. And I really I find, some of the SSRIs to be more on the activating side, like Prozac, for instance, tends to be a little bit more energizing. And so depending on how the patient is presenting also kind of determines which direction I go as far as, medications that I would recommend.
For instance, some people will use the phrase low energy depression. I can't get off the couch. I can't get out of bed.
Right.
When you say activating, you mean it may help that.
Right.
What about the medication Wellbutrin? Yeah, what are your feelings there?
Yeah, so I think from a safety consideration that we are all okay as far as that goes.
In quotation marks.
Yes. Especially if it has been effective for the patient in the past. Considerations with Wellbutrin, because it does work on norepinephrine as well as dopamine, we can naturally see an increase in blood pressure. So for a patient that has previously had preeclampsia, or maybe they already have a borderline blood pressure, earlier in their pregnancy, that's a consideration that we must make.
What type of patients do you think most commonly are taking Wellbutrin as opposed to Zoloft or one of the other traditional medications?
I feel like I see it more utilized as an adjuvant therapy to an SSRI like Zoloft or Lexapro.
In addition to, not a replacement of.
Right. Yes. So Wellbutrin tends to be a little bit more on the energizing side. So not great for kind of underlying anxiety, but tends to be helpful for that like low motivation piece, fatigue that kind of comes along with depression.
Yeah. So we would imagine or envision most women continuing those medications if it's all significant, their symptoms. And, I can remember, I believe it was Zoloft. The same was true about Zofran. And we could get lost in the weeds on this, but, there'll be a report that said Zofran, a common nausea medication, was associated with cleft lip, cleft palate, craniofacial defects. And so everyone stopped using it. And women suffered with severe nausea and vomiting of pregnancy, which is not great for the pregnancy either. But the trouble is people who are not taking that medication have children affected with craniofacial defects.
Right.
So trying to figure out if taking that medication increases that risk over the baseline, that's extremely difficult to do. And often an editorial will land and suddenly everyone reacts. And that's important, I think, to remember because as viewers start reading, it can get very confusing, can it?
Yep, absolutely.
Yeah. And that's where we're looking to someone like you with all this experience to try to guide us. So as we've said, in a general sense, continue those depression medications. Can you think of, I'll put you on the spot, can you think of a medication for depression, anxiety that you would not continue into pregnancy?
So initial literature was sketchy on paroxetine or Paxil with regards to pregnancy. So kind of for a long time, this isn't a medication that we use in childbearing age. It kind of has some side effects as far as it has shown that people may experience weight gain with it anyway. So it kind of is not really our first, second, third, fourth or fifth option probably within the SSRI category. So that would be one, depending on stability of the patient and their, kind of most recent history, if that would be a consideration for making a switch, but not a definitive that we would have to.
Yeah. And to be clear, I think we would say, let's say that you're taking Paxil, you become pregnant. Don't stop it. Get in to see your provider early. See someone like you, if your provider's not comfortable, to say, should I discontinue this? Should I change to something else that maybe we're more comfortable with? But that's a back and forth discussion. But don't just stop it.
Right.
Yeah. Can you think of medications in this category, anxiety, depression, that cold turkey stopping can create problems?
So Zoloft, depending on the dose, sometimes people will have some withdrawal symptoms with Zoloft. Another one in the SNRI category, which works on both serotonin and norepinephrine. Venlafaxine or Effexor is probably the biggest problem child.
It's pretty famous for that.
Yes, for pretty horrific withdrawal symptoms.
Yeah. So you have to taper off of those.
Yes.
Presumably with the guidance of a provider that's comfortable with that, but just stopping immediately can cause some real trouble.
Yes.
Good. So I guess if we break it down and then we would leave depression and go to some other What I wanted to ask you about, though, was people that are taking benzodiazepines. The first one that comes to mind, well, the old one would be Valium. I don't think that's used much anymore. But Xanax, used pretty commonly for panic, for anxiety, and then that woman finds herself pregnant. What is she to do? You thought I was going to let you off easy, didn't you?
Yes. I think, again, it's just kind of a risk versus risk discussion.
Yeah.
Are we utilizing a foundational medication like an SSRI to help bring that panic down?
Yeah.
How frequently of use is this? Are we talking about, a milligram 3 times a day, or is this a small amount of medication that you're using once a month? So I think that kind of plays a role. So it's not an absolute contraindication. I will say that. Not ideal, but there are certainly certain circumstances where that would be an okay continuation.
And not ideal. Those types of medications, Valium and its relatives like Xanax, they can be habit-forming. We worry about, dependence of the baby, and would the baby have signs of withdrawal after being born. But I like the way that you said that. It still may be necessary. And once in a while for a huge problem, as opposed to 4 times a day, those aren't the same.
Right.
And so that's, again, a good conversation to have. So that's a big category we've covered. So depression, anxiety. The next one that comes to mind is attention disorders, of the whole spectrum of them. I think we see that more and more. It's treated more commonly and successfully, fortunately. But that poses a real challenge for people. Speak to that dilemma.
Sure. I think that as we consider the increase in prescribing for the treatment of ADHD, we run into a lot of considerations, because there are certainly non-stimulant options like atomoxetine or Strattera. There is also Wellbutrin is often utilized as a non-stimulant option for ADHD treatment. And then, of course, there are the Ritalins and the Adderalls and the amphetamines and methylphenidates that we can utilize as well. So I think that it kind of goes back to the severity of symptoms, because when we think about, a pregnant patient, and if her ADHD is so severe that it impairs her driving, that's a problem. Or if it impairs her ability to do her job to the point where she may get fired, that's not
good for the baby either.
No. So I think it's again just kind of a conversation of the severity of symptoms and kind of how that intertwines into the management of her safety and well-being during the pregnancy.
You remind me, I think sometimes with those disorders, there's somewhat of a label that goes with it that this is not really important. Maybe you struggled in school a little bit, but now this is adulthood and this is pregnancy, and that's not really important. But that's hardly fair, is it?
Right.
Because people can have debilitating challenges to the point that they can't function. And I think we've seen, as you point out, so many more people are receiving those medications now and doing well, that it's a new problem I don't think we faced a few years ago.
Right.
But don't necessarily stop them. There's hope. But that may be a time to have a detailed conversation with someone with your expertise about, we're not going to stop medication, but we might make a change.
Right.
A different dose, different medication.
Yep.
And that's where your expertise would really come in handy.
Yep. Maybe making a change from an extended release to a shorter acting one if they only needed it, if they were only working, a couple hours a day or something where they really needed that medication. So just reducing exposure, reducing the duration of time that the fetus is exposed, and still doing our best to manage the symptoms when we need to.
Yeah. But that is a challenging category, isn't it? Yeah.
Yes. And again, with the blood pressure, because it does
sure.
work on oftentimes norepinephrine and dopamine. So we have to consider blood pressure and heart rate.
And it's probably worth pointing out, blood pressure naturally goes down in the early weeks of pregnancy. And that's when we often see people, and their blood pressure looks great. But everyone's blood pressure, for the most part, looks great at 8 to 10 to 12 to 14 weeks. It isn't until you start approaching that 20-week mark that everyone's blood pressure tends to come back to their pre-pregnancy numbers. And that's where we might see a problem. So just because at your first visit your blood pressure was okay and you're taking your Concerta or whichever medication, that doesn't mean you're out of the woods, does it?
Right. Right. Absolutely.
Now, do you see these patients in a longitudinal way throughout the pregnancy?
I will. Yes.
That's really nice, because what's working today, it may not in the third trimester.
Absolutely. And we must consider, with blood plasma volume levels going up, that we may require a higher dose in the third trimester.
Yeah.
So,
and I think it's fair to say, I don't think anybody would argue with us that pregnancy is stressful. It can create some bizarre family dynamics.
Yes.
And sleep deprivation and life changes, body changes. It can be bizarre. I think sleep changes are probably that's the thing that everybody experiences and no one talks about. But that could really affect maybe an otherwise stable mental condition. Yeah. So that's two big categories. Let's shift gears, I think, to postpartum.
Okay.
A lot of stuff here. So the last episode of All Things Women's Health was with a great friend, Amber Todd, talking about postpartum depression. We went through a whole program that we've developed to try to label people, screen them, and say, you're at risk for postpartum depression. Let's get a plan in place. That plan in many cases is going to be to see you about optimizing medication, or at least getting a medical plan ready if needed. But what happens in the postpartum period? What are we going to do then?
So certainly, as most of the medications that we've discussed are safe in pregnancy. Vast majority are also safe while women are breastfeeding, which is always a common concern. There are some that can impact milk supply, so that is always something that I do my due diligence in trying to either prepare them or saying, this would be my first option, but here is a potential side effect. And then, we kind of have a discussion on whether we want to switch to something different or try something different instead.
I think several times through the years, I've seen a patient who has to have the medication. Not having it isn't an option. So they say, well, I read you can't take this in breastfeeding, so I just stopped breastfeeding. They lost that chance to breastfeed over misinformation. That's so sad.
Yes.
But in most cases, it's not necessary to stop the medication or to stop breastfeeding.
Right.
Yeah.
Right.
How do patients do in general postpartum if they've done well during pregnancy on a depression or anxiety medication?
Yeah, I think that is kind of variable. I certainly think that doing some work pre-birth can be beneficial. And some of the things that I really talk about in particular with my moms that I'm seeing during pregnancy is, one, we need to come up with a plan to protect your sleep. And that is one of the most vital things when we are considering, somebody that has bipolar disorder that's at increased risk for like a postpartum psychosis. Managing that sleep so they can get a handful of stretch of hours, 4, 5, 6, 7, 8, if you have a very generous significant other or family that can step in and help, is going to be just crucial to improvement in mood.
Yeah. Such a huge part of a postpartum plan. The important statement there is plan, that you don't write when you're in trouble, you write before the problem hits. But having family, having relatives, working out something to try to protect sleep deprivation, because that can be such a trigger, can it?
Yes.
So a plan, the medication may need to be changed, right? Because if it worked in pregnancy, it may not in the postpartum. Another good reason to be plugged in with you or someone like you early on.
Yes.
And then to touch base regularly.
Yes. Yep. Yeah. I'd ideally like to see somebody within, a couple weeks postpartum after birth to just kind of check in and see how we're doing and if there's any adjustments that we need to make. And we have a little bit more opportunity to with regards to doing trials of medications. It's a much safer time to do a trial of a medication postpartum than during pregnancy. If you're just doing something, just to try it, it's probably better to wait till after.
Well, again, it's back to your initial statement of risk versus risk. I mean, it wouldn't be fair to discount the benefit of breast milk for the child that you would be robbing them of if you needlessly stopped. So that's a risk. So whatever risk of medication in theory might cause, it's got to be balanced by that other risk.
Right.
It's always sad to sort of see that happen. Speaking of postpartum depression specifically, I know that you knew I was going to ask you about the new medication that seems to be on everyone's mind, Zurzuvae.
Yes.
Hard to say, harder to spell. It is a new type of postpartum medication. It's taken only for 14 days. It's exceedingly expensive, but at least the manufacturer would say exceedingly helpful for those who are experiencing severe depression. What are your thoughts in general on this?
Yeah, so I have not personally prescribed the medication, so I don't have a lot of feedback.
Yeah.
It does work on GABA, so it does help with anxiety and also helps with, it can be drowsing or sedating. So
to be clear, that's a different pathway that the more traditional Zoloft, Lexapro, those work on.
Yes.
So it's not related in any way. It's not a cousin. It's a different system altogether.
Yep, definitely. So I do think that from an anxiety and a sleep benefit that it certainly has the potential to be beneficial in those regards. Otherwise, I don't have a whole lot of.
We keep getting back to that sleep thing.
Yes.
Right. Our mother's advice: get 8 hours of sleep.
Yeah.
But something that disturbs sleep can be a mess, and so it probably does help with sleep, if nothing else. It is not, and viewers don't misunderstand me. It's not a mainline medication.
Right.
It's been well studied and it's FDA approved, but I think it's fair to say it's really for severe cases. Maybe someone had postpartum psychosis, even worse than depression in a previous pregnancy, and now they're pregnant again. They're terrified that this is going to come back. That could be potentially a lifesaver if it's effective. We struggle sometimes to get insurance companies to approve it, but it can be done. It takes a little work, but it can be done.
Yeah.
Yeah. We also work a lot in our practice with a postpartum progesterone protocol. Have you had a chance to see that be effective, or do you have thoughts there?
I've had a handful of patients from your office that I have seen that do find benefit in the postpartum with that protocol.
Yeah, there was a study done many, many years ago looking at, I believe it was Prozac, comparing it to postpartum progesterone. And the postpartum progesterone was as good or better than the Prozac. And it's certainly bioidentical and easy to do. It's not a cure-all, but I think, as you say, there are certainly some people that do really well.
Right.
They do better the earlier we start it. Sometimes as soon as the placenta's out, we'll start, with progesterone therapy, given a tough history. But maybe the important take-home there is there's a lot of options.
There are.
Yeah, a lot of them. Well, what do you see happening every day by people like me that you wish that you could fix? Where are providers going wrong when it comes to peripartum, during pregnancy, after pregnancy, mood and mental issues?
I think I hear a lot of patients that are told to stop a medication and are not given alternatives. I hear that a lot.
Because that feels like a safe alternative. Just stop it.
Yep. I've heard a lot of still kind of this old thought that at 36 weeks we need to stop an SSRI.
Oh, I didn't think about that. Yes, that's right.
I've had I've heard a couple of those to prevent, withdrawal symptoms in the newborn period. I think those are the two major things that if you are uncomfortable prescribing a medication for a patient that is stable or unstable, that you must give alternative options, or I'm more than happy to see them. So I think that those would probably be my recommendations. Yeah.
Have you seen through the years and through your experience the way the mental health community approaches peripartum, during pregnancy and afterwards, mental health challenges?
I think and this is maybe a little bit more even from my own personal experience, that we expect motherhood to in one way be hard and challenging, and then in another way, social media shows us all the time that it should be the most joyful thing that we've ever experienced.
So if it isn't, something must be wrong.
Yes, exactly. Yeah. But there's no, real middle area with regards to those. So I think that being able to give women in this very vulnerable time in their pregnancy and postpartum period the support that they need, and being able to help them identify that there may be something wrong is another thing that I hear often, is that women, until they're kind of out of this state of depression and darkness, that they didn't realize how dark it actually was until that light kind of lifted.
Wow.
And I hear that a lot. I didn't realize that I wasn't bonding with my baby until it had been 6 months, and I realized, oh, maybe I'm depressed.
Wow. Yeah, I think that sense of isolation, that in the postpartum period, it can be quite isolating. Maybe your spouse goes back to work, you're home by yourself, maybe for the first time not working with a child. Those rooms can get really small. And then I like the idea that sometimes it's the disease talking that tells you, this is how it is. This is how it is for everybody. If you complain, you look weak. That really is the disease talking. And then I know if Amber were here, she would say, this is why we need a plan.
Yes.
Just in case. Everyone needs a plan
Right.
in case it hits in the postpartum period. Hopefully we don't need to get to medications that you and I have been talking about, but we need to have a plan because
Absolutely.
catching up can be a real challenge. Yeah.
Yeah.
So key takeaways for viewers about complex medical management of mental health issues in pregnancy and postpartum.
Yes. So, these are very common. We see 1 in 5 women will experience a mental health condition during pregnancy or postpartum. So incredibly common. So check yourself, check on your mom friends. And for the vast majority of medications that you're currently taking to treat your anxiety, depression, ADHD, bipolar disorder, it is safe for you to continue to take these medications. I just would strongly advise, before making a change, do not abruptly stop them. Call your midwife or your OBGYN and make an early appointment and have a discussion about the risk versus risk that is associated with continuing on medications or starting medications.
Yeah, those are great points. I think I would add on to your second point, a frank conversation with your provider to say, maybe this is not your area of expertise. Maybe you're not really comfortable advising me, and that's fine. There's nothing wrong with that. We all have our different areas of comfort. But providers or patients that might be talking to your provider, if they're not comfortable, have them see you or someone like you, because it's just too important. Yeah.
Absolutely.
Well, thanks for sharing your expertise. I want patients to be able to find you. I don't want them to flood you, but I want them to be able to find you. So how does someone get in touch with you?
Sure. You can go to our website at madetothrivementalhealth.com, and there's a schedule button at the top, and you can request an appointment from there. If you'd like to talk to your provider, there's also a way for them to send a referral to our office. You can always call and text us too, 260-900-2339.
Excellent. Well, I suspect you're going to be getting a lot of calls. I know you already do. But thank you for your work. Thanks for your dedication to women's health, especially in this important period. We look forward to having you back to talk about more topics.
Sounds great. Thanks, Dr. Stroud.
Well, I hope you've enjoyed this discussion on all things women's health. It's an important topic, one of the most important topics facing pregnant women, their spouses, their family, their children. And think about those takeaways. If you or someone you know struggles with a mental health condition that requires medication, keep this advice in mind that we've talked about. Don't necessarily just stop those medications. There is help, there's hope. And if your provider is not comfortable in that space, that's okay. Let's find someone or help you find someone like Delaney who is comfortable. We'd love to hear from you. If you have questions about this topic, I'd love to know what they are. I'd love to get a chance to respond to them. Are there other topics that you'd like to hear about? I'd love to know that as well. Please like and share and subscribe. Share this podcast with everyone you know. And I'll look forward to coming back soon with another episode of All Things Women's Health.